I'm right now at Cambridge Health Alliance GPR doing a year there and then heading back to Maine to practice probably as a GP.
Awesome. Are you guys doing any overdentures there?
So not right now. I did at UNE, but we're probably going to be picking up with implants again in the spring. They took a bit of a hiatus after the last class, trying to recover from a few, I guess, poorly planned cases, but they're planning on bringing it back.
Great. It's such an important skill to have, as I'll go over to my screen here. It's the standard of care now for lower complete dentures. I think many of us know this. What does the standard of care mean? It just means that the expectation is that you offer that to your patients with a strong sense of conviction. If they can't afford it, that's one thing. But in today's day and age, with the technology we have and the wide array of solutions surgically that we have, there's really no reason not to offer this on a regular basis to that particular patient population. One could easily surmise that there are certain patient populations that maybe don't need this, but for the everyday GP in Maine, that definitely exists. Chad, just to be sure, we good?
All good.
Alrighty. Well, speaking of Chad, this is a case that Chad completed recently. Hell of a job. A lot of planning went into this. The particular patient was looking for something that didn't involve denture glue. Long story short, Chad was able to remove the teeth. We placed the implants. These were immediates, Chad, if I remember right?
Yes.
Yeah, so we placed the implants the same day that the teeth came out. We didn't hook them up right away. We'll go over the protocol for that. But just starting here, this is essentially what an implant retained overdenture looks like underneath. These are the locators, and they come in many different forms. We'll talk about the different abutments shortly. This is another picture here I pulled off the internet. Let's go over here. Julie, at some point I'm going to see if you can admit these people on my behalf. Make my life easier. So yeah, implant overdenture. They come in a variety of forms. This particular situation for implants, for me, is the way to go. If I'm going to place 2, it's just as easy to place 4. And it makes a world of a difference for the patient. We'll talk a little bit more about that as we move forward. So this was a picture that Chad had taken. These are the male processing caps that go on to the locators. These metal housings are what get picked up into the denture. We'll see what that looks like momentarily. But what he did is he put this white spacer on and then picked it up like so. These are the pink nylon snappy caps to snap onto the locators. They come in different colors depending upon the retention that the patient needs. But you can see this metal ring right here. That's this right here. So underneath that is the male processing cap, the black processing cap, and then the white spacer here is temporary during pickup. So essentially what Chad had done is reline the denture so that the denture fit passively over these locator abutments with the male processing caps and the white spacers, and then put a curable material. I'm not sure what you used, Chad, whether if it was light curable material like Stellar or if it's a self-cure material like Cool Liner or...
It was Easy Pickup.
Easy Pickup. Yeah, so Easy Pickup is a self-curing material. So he placed it around these. There's little grooves here so that the material sets inside, and when he picked the denture, when it set and he picked the denture up, this is essentially what it looked like. This is after cleaning, so it looks like you cleaned everything up. You can see the junction right here between the Easy Pickup material and the conventional denture base. So looking at it from this perspective, you created space on the underside here until you had a passive seating of the denture. What do I mean by passive? Sitting on the tissue and the tissue only. You don't want to feel or hear any contact with the metal housings. And then you picked it up. and then replaced the black processing caps with these pink ones. We're going to watch a video to go through all of this. Just trying to introduce some terminology. And that was the final result. So that was a upper complete denture and lower implant retained, 4 implant retained lower denture. So very nice job, Chad. Chad, anything about the process? This was your first time doing a case of this kind. What were your thoughts?
Definitely a process. Especially we had some not ideal things back from the lab, so it was multiple try-ins, both for the immediate and for the final. Actually, something that kind of surprised me was if you go back to the other picture with the next one, the housing on the very right side, we were just about to dismiss the patient, and I had him try it out one more time, and he took it out, and the housing on the very right side of that photo was still attached to the locator in his mouth, so it came out of the pickup material. But so we just are going to have to fix it next time he's in this week, but we were all kind of cleaned up already. But that kind of surprised me because it looked like it was pretty well locked in, but apparently those still pretty strong. So
yeah, the viscosity of all of these materials, the Easy Pickup, the Stellar, for those who don't know what we're talking about, it's this material right here. It's the stuff that picks it up. As it sets, if it didn't go into this little lock channel right here, then when you pull off the denture, this, I think what you were saying is this stayed on the locator, didn't come out with the denture, and that happens a lot. I talked to Zest once upon a time and advocated for a light body material that could be injected around this. And they said, well, we don't ever have those problems. And it's like, well, if you talk to the labs often talk about this particular problem existing. So keep in mind that placing the Stellar around this and actually making sure that it gets into those grooves is important, as you experienced. Hindsight's 2020. Looks like you did some electrosurge here, or was this a laser?
It was electrosurge on the distal of his left side, all the way on the other side of the photo, and then at the midline there. But we just used a 15 blade on that other side that you were pointing to.
Oh wow, yeah, it looks. Yeah, I can see it's nice and clean, and that's probably some viscostat.
Yep.
Yeah, and the other nice thing is look at this zone of keratinized tissue that you have. We know through the literature that the success of an implant is dependent upon a variety of factors, one of them being the zone of keratinized tissue. Now, when you went to suture, it looks like this suture line opened. I say that as somebody who's had many of these open. You and I talked about, do we resuture that back closed? And our answer was no, you never resuture something that opens unless it opens the day that you're suturing. And see what happened? It filled in, it granulated in. So you didn't have any problem due to the fact that this papilla, which was once part of your flap, kind of just sitting there out in the breeze, it will remodel. It'll look like this when you're, said and done. This is a picture taken off the internet. It'll look like this in due time as the body starts to heal itself. I mean, this was only, 3.5 months ago that you did the extractions?
Just over 3 months.
Yeah, so extractions, immediate implant placement, everything integrated. We got a CAT scan to confirm the implants healed well. You did some torque testing. So we're getting a little surgical, and I don't like these Monday night sessions to be purely surgical. But as a restorative dentist, it might be good to know, how do you know whether or not an implant is integrated or not? So Chad and I talked about the several different techniques. One of them is the tap test, using the back end of a mirror. When you tap on the abutment or any of the prosthetics that are on there, if you're tapping on metal that's connected to metal that's connected to the implant and everything is tightened, you should hear a ting versus a thud. Chad, were you able to appreciate the difference between those?
Not really, because they all had a very good ting. So
Okay.
I didn't know what the thud sounded like. But
Next
There
slide.
was a very, very clear kings on all of them.
Yeah, it's a pretty significant difference. Teeth that are ankylosed have a different sound compared to teeth that are not. You know, it's not that we should be bashing people's teeth all the time to make sounds, but sometimes it is helpful information. The other method is to do torque testing. If you have the prosthetic driver or some sort of component to go into this little channel here, if you torque at 30 Newton centimeters, if the patient is unanesthetized, the patient shouldn't feel anything. If they feel something, it might be the tissue around it, or it can be the implant is not integrated, and it could be infected. So one of the tests that we often will do is torque testing, which is now being replaced by radio frequency analysis, which is a special tool called the Austell unit, which we have at the office, which requires a special peg. It's hard to have this description without pictures. The point is, it's good to know that things have integrated before you put the locator attachments on. And there's a variety of methods to do that, some of them easier than others. Again, these are the male nylon sleeves. These come in all kinds of different colors. There's 4 or 5 different colors of this style. This is the conventional style. It's the donut shaped one where there's a dimple in the middle. That dimple goes into this channel right here. When implants are off axis, they have an additional line of nylon sleeves called the extended range, which have 4 separate colors. They don't have the dimple here. Playing around with these over time, you'll get a sense of when to use one versus the other. Just know there's a bunch of different nylon sleeves according to how much retention you want. There are some elderly patients that can't pull these out. You know, it's amazing how well these stick, especially when you get to more than 2 implants. So you want to be able to choose the right one for your patients. I've done a combination of different colors. I've done combinations of extended range and regular conventional nylon sleeves. It's an art, not a science, when it comes to selection of these particular devices. Chad, did you go through any process with him? The pink seems like it worked.
Yeah, we just started with the pink, and he was able to get it off and on with some good force, but has no dexterity problems or anything, so he wanted something strong that he couldn't, just easily pop out. So it still impressed him with how strong it was in there to go in and out, and how much pressure he had to even push down with to snap it on.
Right.
But we decided to stick with the 4 pink, and we'll see him on Friday if we want to change those out at all.
Yeah, that sounds like you're right on. There is some loss of retention over time with these. A question asked by patients is often, how often do I need them changed? And my immediate response is always, well, that'd be like a customer buying a car asking the tire salesman, how often do I need to change the tires on my car? It greatly depends upon a variety of factors. But on average, I'd say 6 months is probably the most frequent turnaround time. That's not too common. I'd say a year to 5 years. I'd say the average is 3 to 5 years, at least in my hands, especially when you have nice parallelism. So we're looking at the path of draw here. You can see rather parallel presentation of all of these locators. Because they're parallel, they're less likely to wear. So that's another factor that goes into it. Anybody have any questions about locators specifically? So I wanted to bring up the Misch classification. Carl Misch was I believe he was a general dentist. His brother Craig is an oral surgeon. Maybe Carl was a prosthodontist, but he was more of a restorative dentist. But he really brought the world of implant dentistry into the new era. He has a preeminent textbook on both the surgical and the prosthetic side, and he's known for giving this classification, which is essentially the sites of where implant retained lower overdentures, where the implants go, the A position, the B position, so on and so forth. In a nutshell, the B and D positions are the positions that you would use for 2 implants. There is a conversation about the 3 implant overdenture. I'm not a fan of it for a multitude of reasons, but there are a lot of very successful treatment plans using the 3 implants. That would be the A, C, and the E positions. And then if you do a 4 implant overdenture, it's the A, B, and the D, and the E. You omit the middle, and that's what Chad had done, the 4 implant overdenture. Something like this. So as you converse with the labs and they tell you where that particular arch might need the implants placed, they might use this kind of terminology. What's important to know is the arch form itself plays a role in where you place the implants. I don't have a specific image to talk about that, but in a nutshell, when you have a V-shaped arch, the locations are more the B and the D. With a V-shaped arch, you're more likely to have them a little more posterior. When you have a U-shaped arch, where there's a much more general flowing to the arch of the mandible, you're actually more likely to place them a little more anterior, sometimes between the B and the C and the C and the D. So there's different decision-making processes that need to go into where do you place the implants. In general, the B and the D locations. All of these locations are located between the mental foramina, or the mental foramen. I just wanted to say foramina. The topic of bone resorption is important. So when we look at a panoramic x-ray, we are not seeing this image here. On a panoramic x-ray, these 4 mandibles probably look somewhat similar. Dr. Regan and I have a case right now where the patient has what looks like a lot of bone clinically and on the radiographs, but then you look at the CAT scan and you have something like this. You should know this before you're going into the case. And Dr. Regan and I are working on streamlining this process to better understand who these patients are in the event we don't have a CAT scan. There are tools. Using an endo explorer to kind of poke and bone sound through the tissue is one way to do it. But the point is, don't always expect this kind of mandible. Likewise, the patients who have been in dentures for a very long time tend to present with these kinds of mandibles. These mandibles are very dense. So the bone that you have here is extremely difficult to create an osteotomy on because it's more cortical in nature versus cancellous. So understanding that when you go to place your first implant on a patient like this, you might have to press a lot harder, so you might want to use fresher drills. So understanding the bone makeup prior to going into these cases is absolutely critical. Dr. Regan, any thoughts here? I'm not sure if you're still there.
I mean, I think it's one thing that's really great about the CT is the Hounsfield unit scan, where you can see the bone density in the various areas. I mean, I know in like 2018 and 19, we talked about that a lot. But what was really interesting is we had an oral surgeon at the practice last week, and he is using I think it was called the X-tip. No, the X-tip is a way to get Novocaine. What's it called?
The
X-guide?
Yeah. It was so awesome. But he said that, I mean, the main thing that he's using is the Hounsfield unit projection when he's placing his implants. And he's using that to guide his osteotomies and everything. So, I mean, it's a useful, it seems a little more theoretical the way that at least we use it at our office. It's more of a thought discussion, but yeah, lots of value there in understanding the density of bone.
So Dr. Regan, I am Michael Scott. Teach it to me like I'm a 5th grader. What are Hounsfield units?
Hounsfield units, they are, they describe the density of the bone. It's essentially the thickness, the cortical to cancellous ratio of bone. Dish.
A unit of measure of density?
Too much science. Something physics.
Yeah, physics. All right, we'll take a look at that on the CAT scan. But essentially, it's a measure of how dense the bone is, and Hounsfield units is a unit of measure for density. No different than millimeters are a unit of measure for length. This is a measure of density, which gives you a sense of what is the bone going to be like when I get in there? Do I need new drills? Should I be aware of the potential for primary stability of the implant, so on and so forth. But this is a topic more about the prosthetic side of implants and implant overdentures. So these three terms are used often: implant supported, tissue supported, and implant retained. In a nutshell, a 2-implant overdenture is a tissue supported. The implants are retaining the overdenture, so we can think of it as an implant retained situation. But if you had, say, 6 or 8 implants and the implants went all the way to the posterior, you would then have what's called a implant supported prosthesis. You'll see these terms used in the literature if you're ever diving into that kind of thing. Why is that important? Well, this image does a very good job of articulating the fact that you're going to have compression of the tissue posteriorly, which causes a fulcrum force anteriorly. The better the fit of the denture back here to the tissue, the less rotation you have in the front. So we talked earlier about how do we predict whether or not patients are going to have to change their locators frequently. Well, part of it depends upon the fulcrum. Fulcrum is essentially a unit of rotational force around an axis. The longer the cantilever, the more rotation. So the more anterior the implants are placed, the more likely you are to have to replace those nylon sleeves. So getting somewhat technical about the physics and the biomechanics of a situation like this, but it helps. We had a case recently, Dr. Regan and I. The patient had no bone. His implants were placed more or less next to each other, separated by about 3 millimeters, because that's the only place he had bone. Why is that important? Well, we're going to have to prep him for the frequency of replacing those locators because of how far anterior they are. As a matter of fact, we've had problems restoring him, and I believe Dr. Regan is actually going to create a bar overdenture for him to increase the anterior-posterior spread, which is a concept we'll talk about shortly. But the point is, understanding whether it's tissue-supported or implant-supported helps you to prepare the patient for the inevitable switching out of the nylon sleeves. Somebody had asked for a document. This is a document I've been meaning to put together for quite some time. It's essentially a cheat sheet for the front office to understand what codes go into this kind of procedure. As I was putting this together, I realized that the CDT, the Commission on Dental Terminology, decided to update the codes. Here are the old codes over here. Long story short, these codes right here are accurate. So a semi-precision abutment is the locator, or a ball. These come in many different forms. The locator is just one type. It just happens to be the most popular type because it's the best, at least in my opinion, in many others' opinions. The locator is just one type of a semi-precision abutment. Essentially, the semi-precision abutment is something that gets screwed into the implant. And then we have what is called the keeper assembly, which is a newer term. The semi-precision attachment is the housing that goes inside of the denture. Seen in this side view here, here's the housing, here's the nylon sleeve, and they call that the keeper assembly, those two things together. So I drew in some arrows here. The male nylon insert, which comes in a variety of colors. The case Chad had done, he had chosen pink. Here's the male housing. That's the part that's actually connected to the denture with those little grooves that we were talking about. Here's the locator abutment on the implant. They get screwed into the implant once the implant has healed or osseo-integrated. This is a document. Dr. Regan and I are going to start doing some implant work at a local denturist facility. I put Foundation. Foundation is the name of our surgical mobile company. It's not a real company. It's just we like giving things names.
But it sounds good. It's good.
What's that?
Foundation dentistry. I love it.
Well, you're building the foundation to which the superstructure gets built on. So yeah.
That's right.
That's it. And then implant supported dentures. So these codes right here are important because there are overdenture codes that are tooth-borne. So if you were to open up your CDT code book and look for overdentures, you're actually going to see these codes here. because there was a time when people were keeping the canines and using the canines as the abutment for an overdenture. So when we say the word overdenture, and we're talking about this, we have to put the words implant retained overdenture. The words implant retained before the word overdenture. If you just say overdenture, you're actually talking about a tooth-borne overdenture. It's semantics, but it's important. If you talk to a smart dentist and they call you out on it, please tell them that I told you otherwise, for what it's worth. There was a recent case, I believe Dr. Labani has a patient that might be a good candidate for a tooth-borne overdenture. And I shared with him, it's a super cool technique to do. The problem is the patients often, the abutments often get decayed. But he and I are potentially talking about working with a lab to create an abutment for a tooth-borne overdenture that actually covers the entire tooth, thereby decreasing or eliminating the risk of that happening. With that said, implants don't decay, so maybe implants are the way to go. But I do think there are times when saving those two teeth is the right way to go. Happy to go down that road. If anybody has a patient that, for whatever reason, wants to keep their two canines based on psychological reasons of not losing all their teeth, maybe financial, I'd be happy to have that conversation. My experience hasn't been good with those. A patient that ends up in this arena is not going to take their denture out to brush the two little stubs. And because of that, they get decayed.
Have you used that to open OVD? If they had like their molars still too?
Say that again,
Like
Mark?
let's say you had a patient who they've got a couple teeth, they want a partial, but they also have a collapsed bite. Have you ever done it to use the overdenture part to open up their OVD?
So you're talking about an over...
like they've overclosed, they've worn down their teeth.
Yeah.
They've lost vertical.
Yeah, I'm trying to think the name for those. Where there's actually the partial sitting on their teeth to increase the vertical.
Yeah, it's like you just basically take the impression of the upper, like the occlusal table, and have you done those before?
I haven't. I've seen some, and remarkably, the ones that worked really, really well. My instinct tells me that those that I saw were the ones that survived the 25 years since that was a very common prosthetic procedure back in the day, where they had to open the vertical. I'm trying to think, an overlay denture, I think, or overlay partial denture, I think is what it's called. That's a little different than what I was saying, but those do have their place for cost-conscious patients that need to increase their vertical dimension. Before we're done, I'll pop up a few photos. We can talk about that. What I was talking about specifically were the patient only has the canines. You cut the crowns off, you do endo, and you actually screw in one of these guys into the tooth.
I've had a couple patients come through that have those, and I was curious if that's also what you're talking about.
Yep. Do you know how long they had them? Was it a long-standing treatment?
I mean, it's their final, and they've had it for a long, long time. I've had one patient where hers keeps coming out.
Yep.
It's like a cast one that goes in there.
Yeah. Yeah, there's lots of different tools. From my perspective, it's easiest to just put an implant in because of the troubles that come with teeth. But another treatment option. So if anybody wants a copy of this, shoot me an email after we're done. I'll ship this off to you. I like having references like this, so happy to share it. All right, so this is the conversion process, the chair side conversion. Before I go to that, doing a lab conversion is a possibility where you take an impression of your implant abutments. There are special analogs and special impression copings for the locator system. You send it, and then the lab will actually create a denture base according to the master model that they create. I haven't had good success with it. I've talked to labs about how to make them better. In general, the overwhelming consensus is because of the polymerization shrinkage between the locator abutments, it's best to do it chair side in the mouth on the actual locators and not let the lab process it. So this is a chair side conversion. With that said, I know people that do it and do it well. I think it takes a very skilled lab partnership, one at which I haven't found, at least in this arena. And we've also found great success with chairside conversion. So we haven't necessarily had the need to have the lab do this. Instead, we do it chairside. This is the process right here. So each time I get to this point, you guys have a hard time hearing me. There we go. All right, I'm going to skip out on the sound. I'll walk through. They come in different heights. In order to figure out the heights, you have to measure the gingival collar. To do this, you have to let the site heal. So Chad and I were talking. He asked a question, can I measure this when I place the implant? And the answer is maybe, but you just don't know how the site's going to heal when that time comes. Chad, thumbs up if you can hear me okay?
Yep.
All right. Whenever I go to a video, it seems to screw up the sound, so I just wanted to make sure. So yeah, measuring that cuff of tissue after the fact is important. So what it's saying here is measure the dimension of tissue that's highest at the circumferential nature of the collar of tissue, or the cuff of tissue. So after you measure it, they will send you the proper abutment that leaves you with a 1.5 millimeter surface above it. I often see cases where there's these really tall abutments. I've heard of dentists say, well, I only place the tall ones because I don't have to measure them. Clinical performance is directly related to this parameter being in place, this parameter being 1.5 millimeters. So it might be easy to say, I'm just going to order taller locator abutments and not have to go through this step of measuring, putting the healing cast back on, and then bringing the patients back. I promise you it's worth it. There's a lot better clinical performance as a result. Now, eventually, we're going to have an inventory where each of the implants that we have, this looks like a BioHorizon implant, or similar. This is actually Implant Direct, so it's not BioHorizon, but it looks like a BioHorizon. The green would be the 4.5. Yeah, the 4.5 platform. We would need all of the different sizes. The yellow, we would need all the different sizes. So keeping an inventory of locators is impractical unless you're doing, your practice is doing this all of the time. As a result, there's a step where you literally bring the patient in to measure the collar of tissue. It's kind of a pain in the ass. The patients at that point are ready to get their locators hooked up. Build this into your conversation before you get to that point. So here's the locator abutment. Again, locator is a specific abutment created by the company Zest. Here's the male processing cap. I'm not sure why they're showing this diagram now, since they already showed the measurement. But essentially, that's how the patient arrives. Here's the 5-in-1 tool, also called the locator core tool. It's called the 5-in-1 because it has 5 different functions. This piece unscrews from this piece unscrews from that piece. As we will see, there are several different functions for this one particular tool, which invariably ends up in 5 different places in the dental practice. So this is what you're using to torque it on. Then you take your implant driver, and you torque it to whatever the specifications are for your particular system. It's normally 30 to 35 Newton centimeters. At that point, the locator has been finally torqued. There's no reason to continue torquing it. Metal has a relaxation state, So I typically wait 5 to 10 minutes and then go back after and retorque again. I haven't found the need to do that with locators. With that said, anytime you're torquing prosthetics down, it's good to wait 5-10 minutes and then torque one more time to whatever that number is. This is an angulation tool to determine whether or not you need extended range locator attachments. Essentially, anybody except Dr. Phillips needs to use this. His implants were perfectly parallel, so he didn't need to use this tool. But it's good to know what is the potential divergence of the implants. We use the CAT scan for this purpose. Here are the standard nylon sleeves. And here are the extended range. Again, the extended range does not have the dimple in the center here. They come in a packet like so. This is the part that we were looking at early in the presentation. We were looking at the other side of it. This gets placed on the locator. It's a blockout spacer to prevent material from locking your denture onto the abutment. Never makes for a good day when you have to cut a denture out of somebody's mouth. Did it once, and won't do it again. So make sure you have those in place. And then this snaps on. That black piece gets replaced by this piece once it gets picked up by the denture. I love how accentuated that uvula is for this demonstration. So you snap those on, it does make a noise. Here you reline the inside of the denture. Here they're using, I think, Fit Checker. You just have to make sure that that processing cap that's on the locator is not preventing the denture from seating down all of the way. So using some sort of disclosing solution, whether it's PIP paste, I sometimes use bite material, light body, there's all kinds of ways. To be honest, I just kind of seat it down, and I get much more aggressive with hollowing the denture out now, just to make sure I'm not spending an hour trying to find out the exact amount of acrylic to remove. I've never used this, but it might be a nice tool to use. That's new. I think we'll be ordering that. And that's new also. So this is the step I was talking about. It looks like this particular company uses a syringe. The stellar material we have allows it to be placed like that. There could be a pretty good conversation about how hard you have the patient bite down. Medium. I sometimes will use my fist on the patient's shoulder to portray to the patient what that means. You don't want them biting down too hard. You don't want them biting down softly. So there is the right amount. I was actually trained in my residency to do it by hand, but I find if you do that, you lose the opportunity to make sure it's in class 1 occlusion. So just know that you have to be conscientious about having the patient bite down when you're doing the chairside pickup. Here they say light occlusion and hold the denture processing as the material sets. Excessive occlusal pressure may cause tissue recoil. That's what I was talking about if you press too hard. You often have to reline some voids. You want to make sure that there's no areas for bacteria to get in. This is another new tool here. So I think we get the idea. And then here's the male insertion tool. Pick up the cap that you want, snap it in. It requires quite a bit of force to do that. It looked really easy on this, but it's actually a little more difficult. And then you snap it in. And then you ask the patient to remove it and see if they have good retention. Any thoughts, questions? Chad,
They made that look so easy.
Yeah.
That was great. Took like 2 minutes.
Yeah.
That was awesome. I end up doing a lot of back and forth. I mean, I think the most important part is getting the reline nice. Nick, when do you do your soft reline? After you've set it, or do you do a soft reline before you do the conversion for them?
I only do the soft reline after the surgery, especially for an immediate case.
I'm talking about for like the conversion. Are you going to soft reline them the same day you do the conversion? Or what if they're already stable, how they have been, and now you're going to add the conversion for them?
I don't typically do a soft reline at this step.
Yep.
Yeah. At this point, the tissue is healed. I guess the answer to your question is I do a hard reline, and I pick up the entire intaglio as one. I'll actually do the whole thing.
Okay, that's what I thought.
Yeah, I think you and I have had a few cases where we've done that, so I know where the question comes from. When you have a significant amount of bone change, you often have to do a reline. But now that we're doing more bone resection, where we're actually flattening the ridge, we have a lot less bony changes after the fact, so we don't necessarily need to do that reline. It really depends on the timing. So I know the question, and it's hard to articulate through words alone. But I think you make an important point that sometimes we have to reline the intaglio in addition to picking up the denture.
Yeah.
Yeah. All right, so here's the... Yeah, go ahead.
I had there were two things that came to my mind that I wanted to share just from that experience. First is selecting the tissue height. I found that they're on the most distal two. The distal tissue was at like 6 millimeters, and the mesial tissue was at like 2, and that's why we went in and removed some of that tissue. But I was like, wait, what height should I choose if it's so different between the mesial and the distal?
That's a great point. So you made the tissue adapt to the situation rather than the other way around. And that's a very good point, and one at which, what could we have done differently during the surgery to minimize that tissue being there?
Yep.
These are the things that the restorative dentist asks, but the surgeon never really knows is necessary unless you let things heal long enough. But when you're the restorative and the surgical dentist, when you were cutting this away, I'm sure you're like, well, what could I have done as I sutured this closed 3 months ago that would have prevented that from happening? And these are all great questions. But I like what you said. You made the tissue adapt to your situation.
The third thing was that once we decided that we were going to remove some tissue, that locator that we used, just the 15 blade to remove the tissue, we did the 15 blade because I couldn't get that locator off, and I tried really, really hard.
Interesting.
And I even had Dr. Libby come in with the core, I was trying with the core tool, and had Dr. Libby pop in and try it with the core tool, and he couldn't get it off either. And if Dr. Libby can't get it off, then I was like, all right.
Let's be accurate here. You brought him in for his muscles, and
yes. Oh, no, exactly, yeah.
And he couldn't get that off. So
no.
What do you think was keeping it retained there?
I have no idea.
Huh. So what did you end up doing?
That's why I did the 15 blade instead of the electrosurge, because I just didn't want to risk the electrosurge and the implant there.
Gotcha. Huh.
So ideally, I would have taken it off, used the electrosurge, and then put the locator back on, but couldn't get it off. So.
Yeah. Yeah. Anything else, Chad, from that?
No, just those two things.
Yeah, great insight. This is the tool. You can order this from Zest. I believe there's other companies that make it. This little thing here helps you to remove the nylon sleeves when you go to replace them. This is the insertion tool. This slides into that for no reason other than it's just one tool altogether. And then this guy slides in here, but this is the working end here. So it's placing the abutment here. You put your driver, implant driver here, your hex on the inside of this, torque it to its final torque. Then you come in, you pick up your insertion tool, place it in, and then when you go to remove them at some point, you place that in. But I guess you actually use this one first to take out the black processing cap. I guess that's why they put that in that order. So yeah, lots of good YouTube videos on how to use this tool. So feel free to take a look at that. Kelly did order a few more for the practice. Invariably, these things end up not staying together. So we had to order a few extras to make sure that we knew where they were. As I was putting this together, this slide came up. The idea of angled locators, locator abutments. Long story short, implants don't like lateral forces. So if you're not putting a locator directly over the long axis of the implant, you're going to have a vector of force that's going to stress the implants laterally. These are becoming more popular. The MISH literature was pretty clear that these won't work, especially as they get taller, your fulcrum forces get greater. I would stay away from these. Locator came up with, or Zest came up with the extended range nylon sleeves, which make up for angulation defects, but not necessarily changing the angles themselves. So then it led to this particular image here. Angled implants are not good when they are by themselves. Splinting these together, like you would with an all-on-4, you can tilt implants for days, but they're splinted. They don't receive any of the axial force down the long axis of the implant when you're biting on that one particular implant. But single implants, whether it's a single unit crown or any situation for that matter, angled implants when they're not splinted is a no-go. Any thoughts or questions? It's a pretty important topic. Obviously, there's times when you need to, but you could, let's say you had to place these two implants like this, what would you do? Patient needs to have an overdenture based on financial reasons.
Use
Would
the
you do
cord-
extended
cordless
range
sleeves.
nylon inserts?
So you could do the extended range from a absolutely extended range, but there's a prosthetic solution to minimize the off-axis forces here. Zach, I think you were saying something. Yeah, a bar. So what is a bar overdenture? It's essentially connecting these two, and the locator goes on the bar. So let me actually pull that up right here. They're a little more technical. You have to work with a lab that knows how to do this. But essentially you can make up for off-angled implants by using a bar. Now that we have milling technology, this is becoming more and more popular. So what's nice about a bar, you can have off-angled implants, and then the locators are actually placed on the bar perfectly symmetrical to the occlusal plane, or perfectly parallel to the occlusal plane. A bar like this, milled of titanium, might run you, I don't know, Zach, you and I have talked to labs about this. Do you remember what the cost was?
I think it's about $1,000.
Yeah, I mean, it's not inexpensive by any stretch. Zach, you want to talk about that case? Is it Richard, I think his name was?
Yeah, it was Richard, and I think you actually brought him up earlier. So this patient he had bone just pretty much just at the C position. So his implants are 3 to 5 millimeters apart, just right at that most anterior extent. And he has some soft tissue support in the posterior region, but he's able to compress it. And we've tried hard relines, we've tried soft relines, we've tried everything to develop some stability for him. So at this point, what we're doing is we're going to add a longer bar that's almost going to give us some extended stability in the anterior component of the denture, and hopefully work with him to decrease that rocking.
Yeah, so we're increasing the anterior posterior spread. So let's just use this image right here as an example. The two implants based on the bone available to you, the two implants are like right here. So there's a lot of rotational forces. So what Zach will be doing is connecting the two implants, but the bar is going to go like over here. Anterior posterior spread is a term used more in the fixed world, all on fours and things like that, to know how far you can cantilever off the most distal implant. But the topic here works where you're doing a bar overdenture. The bar allows you to extend more posteriorly. These are called Hayter clips. The Hayter clips was a very common bar overdenture system in the 90s and the 2000s. They work. They're just technically demanding, and when they need to be replaced, they're not easy to replace. That's why locators are so valuable of a solution, because they're easy to modify, update, add, subtract, change out the nylon sleeve, so on and so forth. It's a much more agile system, which is why I would imagine most of us hear about it the most. So this is a bar overdenture.
What are your...
Yeah, go ahead, Mark.
Sorry, that was me. I didn't mean to interrupt. Carry on, I'll wait.
Oh, is this Elijah?
Yeah, that's me.
Yeah, go for it, man.
I was going to ask what your thoughts are on a single implant overdenture at the C position.
Yeah.
Not necessarily in this case that you're talking about, but in general.
Yeah, it's a good question. I've seen it. It's been studied, and I think the answer comes down to the fact that there's rotation around the implant. The denture itself loses a lot of the stability by not having cross-arch stabilization of sorts. So it just kind of rotates in that C position. It's been discussed a lot for cost-conscious patients, but I think what replaces that is the mini implant, which is something I wanted Dr. Regan to talk about. So could there be a situation that's the right answer? Maybe, but I think biomechanically, because of the rotation around the implant and then the rocking back and forth as the patient's chewing one side the other, would put a lot of stress onto the locator, because it's acting as a retentive tool but also a supporting tool. So there's a lot of rotation around it. Is that something you've seen?
So I didn't realize my mute was off the whole time. But yeah, no, I've also read about it. And I recall the papers I read that they were for cost-conscious patients and seemed to do pretty well in comparison to a conventional implant or a conventional complete denture.
Yeah.
So I guess the comparison.
Yeah, I think the struggles that we're having with Dr. Regan's patients, essentially that's they're so close to each other in a V-shaped arch that they're, for all intents and purposes, a single implant, and it's been pretty challenging. With that
Elijah,
said,
I just want to put something out there that no good deed goes unpunished, and the patient's cost conscious, but the number of follow-ups you're going to see them for is going to be, well, just ruin your day.
Yeah, that's a good point.
Yeah, good question though. Zach, you want to end with mini implants? I'll preface it by saying Zach took his maxi course, which is a year-long implant train. I say implant training. It's a full surgical residency for that matter. He went down to Boston once a month for 10 months. That's called a maxi course. I did my maxi course training down in Georgia. There was no Boston course when I decided to do that. So I had to fly down there, which was a lot of work, but a lot of fun. But his course talked a lot about mini implants. So he's taken the course by a guy named Brian Jackson, who's well known for advocating for mini implants. And Zach's like, hey, let's do some mini implants. And I'm like, no, they're stupid. Long story short, we have a full inventory of mini implants now. Gordon Christensen talks about their stability and their longevity. I've talked to 3 clinicians since then. I have no experience with them. It's new to our practice, so whatever Zach says, it comes from regurgitation from the maxi course, which is a very valid resource. But I think there is a place here for the cost-conscious patients to drop in mini implants. So on that note, Zach, you've got 30 seconds. What are your thoughts on mini implants?
Mandibular overdentures is the only true solution for mini implants. If you want something that's going to work, that is cost conscious, it is only for mandibular overdentures, never maxillary. That's the clear takeaway. There's some literature supporting the use of upper and lower arches, but by and large, mandibular overdenture is the safe way to go.
Great. Yeah, as Zach and I enter a patient population of very low socioeconomic status, I'm pretty sure we're going to have some reps under our belt soon enough. Anyways, I hope everybody has a somewhat clearer picture on this whole world of implant overdentures. It's an absolutely fun and very straightforward process to go through. Chad, I think you went start to finish on it, and the case came out great. It's a testament to your clinical skills, but also how predictable this treatment can be. You know, if we were to start to get into bar overdentures with hater clips and things like that, we probably would be having more headaches. So on that note, Google's going to kick us out shortly. Does anybody have any last minute questions on implant overdentures? Alrighty, off to Monday Night Football. Everybody have a good night.
Thanks. Have a good one.
All right, you too.
See you guys.